From Microbe TV, this is Infectious Disease Puscast, episode 58, recorded on July 3rd, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm back. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Thank you, Daniel, for covering for me. I sort of just lost my voice, so it would have made a not so pleasant podcast listening experience. So, but there were a lot of good articles, so I'm glad you were able to cover those in my place.
Yeah, well, I'm glad you've got your voice and everything else back and that you can be here. It actually made me think, like, we should probably have something. I was thinking, well, if you can't speak, what are we going to do? But we should at least have, like, some, like, people who do American and international sign rights so that we're, opening up to a broader population. So, but I'm glad that you have the voice and we can work on extending our listenership.
Yeah. And then happy early July. I guess it'll be past July 4th after this eventually comes out.
Yeah, this will drop after July 4th because, the production time on this for some reason is a little longer than some of the other shows. Today
Hopefully
is my youngest brother's birthday, though. So, Ben is turning some age, and I don't mention it because it's always like 20 years younger than my age. So if we know that he's turning 38, people who can do math would know that I am getting older.
I see. Yeah. Leave it mysterious. It's much better.
Yes. Only people who can do math know how old I am.
Yeah. All right. Well, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, we'll start with the viral section, and remember to listen to TWIV, the deep dive, and the clinical update. But I have to say, this first one is so good that I'm going to mention it here, but I'm also going to mention it on the clinical update. So, those who listen to both, you're going to get it twice. But here we go. So, our listeners of the Infectious Disease Puscast who also listen to the TWIV clinical updates might remember the study where it appears that coffee can inhibit multiple variants of the SARS-CoV-2 infection by restraining the binding of the SARS-CoV-2 spike protein to the human ACE2 and reducing the transmembrane serine protease 2, TMPRSS2, and cathepsin L activity. Remember that? Well, people who listened to TWIV heard this last week, but it was suggested that we should all be drinking and perhaps inhaling a little bit of coffee. I think it was Vincent who looked closely and was like, I think you need to aspirate the coffee because they were spraying it into the lungs.
My favorite form of having coffee.
Yeah, so now, when someone tells you that horrible joke and it goes up your nose and into your lungs and you start coughing, they're just trying to protect you. Exactly. But apparently this week we have the article, Cannabis, Tobacco Use, and COVID-19 Outcomes, where they tell us that smoking on the weed may not be the best idea. That's the expression you kids use these days, right? Smoking on the weed.
I don't think I count as these kids anymore.
Well, in this study of 72,000 patients, they reported that current tobacco smoking was significantly associated with increased risk of hospitalizations. We got odds ratio 1.72, ICU admission odds ratio 1.22, all-cause mortality 1.37. And what about smoking on the weed? Well, cannabis use was also significantly associated with increased risk of hospitalization. And dare I say, even a bit worse. Odds ratio 1.80, ICU admission 1.27, but apparently not all-cause mortality.
Nice. So I pulled a Clin Micro review, which I realize I haven't talked about one in a while, but I pulled this one out, HIV-associated cancers and lymphoproliferative disorders caused by Kaposi sarcoma, herpes virus, and Epstein-Barr virus. So this is a nice review of really everything, epi, virology, clinical manifestations, treatment of cancers caused by EBV and KSHV in persons living with HIV. And I always find it quite incredible that the discovery linking KS with AIDS actually wasn't sort of formally determined until 1996. It's not that long ago, when they discovered the KSHV or HHV8 in KS tumors.
I think there was
There's
like a medical student actually, Sarah. I think it was like a medical student
really,
at Columbia did this. Yeah.
yeah. I mean, we talk about a lot of things like when they're discovered, but it's just like it's one of the few things that really strikes me. But there's lots of paper details in the paper, lots of wonderful figures. I like figure 2, for example, links various gene products with sort of the hallmarks of causing cancer and latency, things that the viruses do. I learned a little bit about non-coding RNAs and gamma herpes viruses, which is basically various types of RNA that do not code for proteins but can have different functions in the cell. And herpes viruses are one of the few virus families that can encode their own micro and circular RNAs, which can provide some strategic advantages to the virus during infection and establishing latency. So I didn't realize, I guess some of this field is a bit more recent and there are some challenges to identifying and studying those, but I don't have a ton of background knowledge, so I learned a bit there. And then, of course, there's some nice clinical overviews, like figure 4 has the some of the KS clinical manifestations. And so they break down the HHV8 associated diseases, so KS and its multiple forms, KSHV associated multicentric Castleman disease, primary fusion lymphoma, KSHV associated large cell lymphoma, and then the KSHV associated inflammatory cytokine syndrome. I think all of us have seen those tables that sort of put those side by side. And then they cover some of the subtypes of EBV associated malignancies, so diffuse large B cell, Burkitt lymphoma, primary CNS lymphoma, plasmablastic lymphoma, classical Hodgkin lymphoma. So really, really nice summary of a big topic that actually came up. Several of these came up the last time I was in service, not even that long ago. So nice review.
Yeah, and I think this is important, right? Because there's this whole idea out there
Yeah.
that now that we have medicines and having HIV, it's just fine. You're going to live just as long as everyone else. But I think it's important, right? I mean, the HIV-associated cancers, and then just the incidence of some of the other cancers, occurring, lung cancer occurring at earlier ages, more
Yeah.
breast cancer also occurring at earlier ages. So it's always
Yeah.
important to.
I think outside of ID, people kind of forget how many different things that EBV can cause havoc and issues with in patients with HIV or, even after transplant and those types of lymphoproliferative disorders. So yeah, very
And
interesting.
I Googled the KS story. So apparently the pathogen was ultimately identified by Juan Chang and Patrick S. Moore, a wife and husband team at Columbia University. And I
Oh,
think
I
there
didn't know it was
was
a
like a
Columbia.
medical student working in the lab or there's some more to the story. So if our
That's
listeners know
cool.
the details,
Yeah, they do list them by name on paper. I remember reading the couple folks. I'm sure it's a lot more than the 3 people they put on there, but
right? It's always like the two people running the lab. You're like, really?
yeah. And then everyone else that they work with. Yeah.
And then there's a medical student who's like, don't actually come into the lab. You stay there and write the grants and get us some more money. But anyway, okay.
Yeah. Yeah.
Well, another one here talking about HIV, and this is the article Post-Mortem Analysis of Dolutegravir, Tenofovir, Lamivudine, and efavirenz penetration into multiple CNS compartments, published in JID. And dare I say, it's really interesting. And I remember walking around in my pocket. I had this CPE. It was like a piece of paper where I had this all out. It had the CNS penetration efficacy of
Yeah.
each different drug, and I would get the right number of scores. And this was right after someone presented an abstract, I think at Croy or something. Well, how accurate is that? Well, here, dolutegravir, tenofovir, lamivudine, and efavirenz concentrations were measured across 13 CNS regions plus plasma in samples collected during autopsy in 49 Ugandan decedents. Median time from death to autopsy was 8 hours. And they're going to evaluate the postmortem redistribution. A time course study was performed in a mouse model, right? So we've got these Ugandan decedents. We're measuring levels, but then we're going to use this mouse model because some time's gone by. Now, regions with the highest penetration ratios were the choroid plexus and arachnoid, and that was dolutegravir and tenofovir, the CSF lamivudine, and cervical spinal cord meninges efavirenz. And the lowest were corpus callosum, dolutegravir, tenofovir, the frontal lobe, and the parietal lobe. So sort of interesting, we're seeing different penetration in different areas, but on average, brain concentrations were 84%, 87%, and 76% of CSF for dolutegravir, tenofovir, and lamivudine, respectively. It's kind of nice, if you got a CSF level, you're getting about, 76 to 87% penetration. Now, the postmortem redistribution was observed in the mouse model, and the tenofovir and lamivudine concentration increased by 350%, and the efavirenz actually decreased by 24%. So it's changing over time when you look 24 hours postmortem. All right, now this one, sort of came to mind. It was interesting because some recent stuff that we've seen in the hospital, but the article, New Insights into the Therapeutic Management of Varicella-Zoster Virus Meningitis, a series of 123 PCR-confirmed cases, published in OFID. This is a retrospective cohort study conducted in Paris, France. Included all adult patients with cerebral spinal fluid that was positive for VZV by PCR. Included 123 patients with meningitis. And now this is interesting. Among them, how do we treat VZV meningitis? So among them, 14% received no antivirals. Well, we normally would not recommend that. 20% were treated with oral valcyclovir alone. 41% got what I think is pretty standard, where they get a short course of IV acyclovir, then they switch to the Val acyclovir. And 25% just got a long course of the IV acyclovir. Now, the interesting things, right? This is something I've sort of learned as I've practiced in different settings and seen different styles. Outcomes were favorable regardless of the antiviral regimen. So there's this idea, the pharmacokinetics are such that actually, even though it's oral, but the oral valcyclovir, gets high levels, gets high intracellular levels. Maybe we don't need that IV that we are wed to when it's a CNS infection. And here we're seeing similar outcomes.
Surprised that almost, 14-15% didn't get any antivirals.
Yeah, it's actually, I'm thinking they may have I'm not sure exactly what happened there.
Yeah.
That would definitely not be the standard of care. Well, I guess it is the standard of care, right? That's what standard of care is. 21% of the time, we don't treat them at all, but no, not recommended. All right, we got a few here in Bacterial before I let Sara jump back in. But be sure to listen to This Week in Microbiology. There have been some great episodes recently, so I've been really enjoying those, and you should too. But I must say, I feel like everyone missed the memo on this first one. The article, Carbapenem Use in Extended Spectrum Cephalosporin-Resistant Enterobacteriales Infections in U.S. Hospitals and Influence of IDSA Guidance, a retrospective cohort study published in the Lancet Infectious Diseases. And this is one of the nice things about being in a group where my partners feel like they can kind of give you a nudge and be like, you really shouldn't be doing that as much as everyone else seems to be doing. Well, I think we need a little context here. So here's what we learned. Due to disparate and rapidly changing practice recommendations from major professional infectious disease societies for managing non-severe infections caused by extended spectrum beta-lactamase producing Enterobacteriales, I understand the confusion. The use of carbapenems is largely undisputed for severe ESBL producing Enterobacteriales infections after the large multicentric Merino trial published in 2018. That was during your time. You're not too young for that, Sara, right?
Yeah, I was starting fellowship.
I remember when this came out, and we're at Columbia, and the pharmacist is presenting it, and then we get kind of the after effect when the study was properly analyzed with accurate MICs. Oh, they actually were not able to show this non-inferiority of the pip-tazo to meropenem, right? So the sort of statistical significance goes away for, but this was you got to stop using Zosyn for ESBLs in all situations. Merino's great. And then it's well, I didn't quite get there. There is a trend. Now, E. coli and Klebsiella pneumonia there seem to be many of us who interpret this as compelling for using carbapenems for serious infection. I think that's fine. But what happens next? Well, the 2020 version of the IDSA, right? So this is 2018. We get Marino. We're all excited. The 2020 version of the IDSA expert practice guidance for antibiotic-resistant gram-negative infections. Basically, I love this. Recommended liberal use of carbapenems for uncomplicated UTIs and pyelonephritis and all ESBL-producing Enterobacteriaceae infections outside of the urinary tract, irrespective of illness severity, right? So just let the carbapenems flow. Well, the first to sort of take issue, 2021, the European Society of Clinical Microbiology and Infectious Disease guidelines say, you might want to limit the use of carbapenems to those severe manifestations, such as septic shock or bacteremia. So then a little time goes by, the IDSA updates their guidance in 2023. And unfortunately, I don't think that many people read the updated 2023 guidance. I think there was a febrile episode, right, covering this?
I feel like I refer to it all the time.
So maybe we'll tweet that back out there, but I will leave a link into this updated
They are good episodes,
guidance.
yeah.
And here the IDSA suggests maybe a little bit of carbapenem stewardship. Let's take those carbapenems and let's remove them from the first-line options for the complicated UTIs, pyelonephritis, even though it's an ESBL, and let's reserve those for the more severe cases. Well, as I say, no one got the memo. So between January 1st, 2018 and December 31st, 2021, 30,041 inpatient encounters with extended spectrum cephalosporin resistance, so ECR, Enterobacterial infections were identified at 168 U.S. hospitals. Although few patients received carbapenems empirically, many did so as targeted treatment, including subgroups of patients, dare I say, without septic shock, and patients with UTIs without septic shock, in whom specific narrower spectrum alternatives were active. Now, carbapenems were the predominant choice to treat ECR, extended spectrum cephalosporin resistant Enterobacteriaceae infections over time, with no additional immediate change after the IDSA guidance release. So just maybe we'll get the memo out here for everybody. Maybe you should put in a link to that febrile episode too.
Oh, yeah. I have to remember. The only problem with naming the titles weird things is I have to remember what they are.
Yeah, we get back and forth.
I'm pretty sure one of our cases is it might have been a complicated urinary tract or something to kind of talk about this. And actually, one of the articles I pulled sort of kind of has to do with this too.
All right. Okay. Well, I'm really concerned that people missed the memo on this next one as well, Sara. We have guidelines for community-acquired pneumonia, yet everyone gets Vanco and Zosyn instead of ceftriaxone and azithro. I was giving a lecture one time, and it was a bunch of ER docs, and you could tell they minimal interest in what I had to say. It was like peanuts, and the parents were talking. And then finally, like, hey, any questions? They're like, so yeah, when should we not give Vanco Zosyn? I'm like, oh my gosh, okay, never mind. All right, well, the article, Guideline Concordant Therapy for Community-Acquired Pneumonia in the Hospitalized Population, a Systematic Review and Meta-Analysis, was published in Open Forum Infectious Disease. So after doing an extensive search, they included 17 observational studies, 82,240 patients, of which 10 studies were comparative and pooled in a meta-analysis. Overall guideline adherence rate was a whopping 65%. Guideline concordant therapy was associated with a statistically significant reduction in 30-day mortality. Look at this. Using ceftriaxone azithro instead of throw in the kitchen sink vancomycin, 30-day mortality odds ratio of 0.49, a 50% reduction in mortality if you stop using so much vancomycin and actually follow the guidance. Now, in hospitalized patients with community-acquired pneumonia, guideline concordant therapy was associated with a significant reduction in mortality compared with non-concordant therapy, such as vancomycin. But a few interesting findings. And I think this is important. Although the pooled odds ratio is suggestive of overall mortality benefit of guideline concordant therapy, administration of empiric anti-MRSA therapy in high-risk patients as recommended by these guidelines was counterintuitively associated with an increased risk of 30-day mortality. And I try to point this out, that the utilization of broad-spectrum antibiotics, piperacillin, tazobactam, and vancomycin has increased, and we just pointed out that not such a good thing, yet the rates of isolation of these multi-drug-resistant pathogens such as MRSA and Pseudomonas have remained unchanged.
Okay, so next I pulled an article from CID, Piperacillin Tazobactam Susceptibility Test Interpretive Criteria for Enterobacterales, recommendations from the United States Committee on Antimicrobial Susceptibility Testing. So this is kind of related to what Daniel was talking about, not exactly. I think many listeners probably know there's debate on the role of piperacillin tazobactam, I'm going to say pip-tazo, in the treatment of infections caused by ESBL and AMC-producing Enterobacterales. This reviews the U.S. CAS, so that U.S. Committee on Antimicrobial Susceptibility Testing, their recommendations and rationales for recommending against providing pip-tazo breakpoints for certain Enterobacterales species, so those with moderate to high likelihood of clinically significant AMC production. So that is Enterobacter cloacae, Citrobacter frundii, and Klebsiella aerugines. So those same sort of big three that are mentioned in the IDSA AMR guidance. And then for third generation cephalosporin non-susceptible Enterobacterales. So the abbreviation is like 3GCNS, but basically a phenotypic marker for ESBL expression. And so their recommendations were slightly different from the FDA and CLSI and UCAS, which is the European Committee on Antimicrobial Susceptibility Testing. And so I won't go into it too much, but that first portion, not recommending a piperacillin tazobactam susceptibility breakpoint for those with the moderate to high AMC production, that aligns with the current IDSA guidance and is based on the high potential for selection of de-repressed AMC mutants during pip-tazo treatment, and then the lack of in vitro activity of pip-tazo against these, and sort of their interpretation of Merino 2. And then those sort of major second and third recommendations against a breakpoint for pip-tazo against those third generation cephalosporin non-susceptible Enterobacterales, which is a mouthful. And then they do give a breakpoint of less than or equal to 16/4 milligrams per liter for third gen cephalosporin susceptible Enterobacterales, but only endorses the use of extended infusion pip-tazo regimens for infections with those pathogens. So to summarize that, there's a really nice sort of summary of all of this in Table 1. And I remember trying to wrap my head around this in fellowship, and I think at one point picked it as something to give a presentation on just to help myself walk through. But I think what is really nice to point out is, especially for new fellows, that there are so many different organizations that help lead and provide recommendations for susceptibility criteria and setting breakpoints, and it's quite a complicated process. And you can see how, some of the differences might be explained by how people dose antibiotics globally, but really it can also just be different interpretation of almost identical data. And so I think if this is something that's interesting, there's lots of ways I think you can probably get involved, and they often ask for like ID community feedback. But I think when these come out, it's always really nice to try and like have an understanding of how they get to the point that they do, rather than just sort of looking at the numbers that show up on the reports. So I think I tried to put a picture from that Table 1, and then Table 2 has also the previous susceptibility criteria for Enterobacterales.
Yeah, it's amazing, how complicated this is. And I just worry about those,
Yeah.
80% of counties that have no infectious disease specialist to guide them through. And maybe this is something where the stewardship and the telehealth stewardship and all the support that's being given can help with this. Because, we want our patients to get optimal therapy. There just aren't enough infectious disease docs out there.
Yeah.
All right. Well, this is sort of interesting, and I'm going to be curious to see how this actually gets rolled out, gets implemented. But we've got a newly approved 21 valent conjugate vaccine for strep pneumonia, Capvaxive, made by Merck. And I'm going to leave in a couple links. So there's like, there's the FDA vaccines biological information where we get where they talk about all the different serotypes. But there's also a news in brief in Nature that's unfortunately behind a paywall. But this is actually, say, if you're going to read one thing, this is a good one to go to. I'll share it with you because it might be behind that paywall, but it's the article FDA approves 21 valent pneumococcal vaccine. And this is Capvaxive, protects against 21 serotypes, including 8 serotypes that are not covered by Prevnar 20 or any other FDA-approved vaccines. And this is to curb infections, they say, especially in older adults. There are around 100 different serotypes of strep pneumoniae that cause pneumococcal disease, and these can affect children and adults. The 21 serotypes covered by Capvaxive are responsible for, you ready for this, 84% of invasive pneumococcal disease cases in adults over 50. So says the company. It's actually true. Whereas the serotypes that make up Prevnar account for 52% of the cases. All right, where's the Prevnar person defending them there? Now, Capvaxive was non-inferior to a single dose of Prevnar for the 10 serotypes covered by both vaccines. And sort of silly, but they tell us that Capvaxive was superior to Prevnar 20 for 10 of the 11 serotypes included in Capvax, but not in Prevnar 20. So I'm sort of curious to see how this kind of unfolds and how this gets introduced into practice. All right. Now, the article Antimicrobial Resistance Patterns of Outpatient Staphylococcus aureus Isolates was published in JAMA Network Open. Now, the authors start by pointing out that oral non-beta-lactam antibiotics are commonly used for empirical therapy of Staph aureus infections, especially in outpatient settings. And I will say that this is also the situation in many hospitals where people are covering, with quotes around it, Staph aureus in their empiric antibiotic regimen. Well, here we have the results of a cross-sectional study that used data from Veterans Health Administration clinics collected from adult outpatients with Staph aureus infections in the, I don't know if you've heard this term, the counterminous 48 states. I would say it's contiguous, but all right, and Washington, D.C. The data was analyzed from January to November 2023. So right now, people wanted to cover staff might use, and let's look. A total of 382,149 Staph aureus isolates from 268,214 unique outpatients. They're going to analyze this. Now, interesting to start with some good news. There was actually a decrease in the proportion of MRSA nationwide from 53.6% in 2010 to 38.8% in 2019. Now, the resistance, though, this is the bad news. So among those remaining, and there's a lot of them, MRSA isolates, tetracycline resistance, right? So think about your doxycycline. I can use some doxycycline. I'm sure that'll work. Well, you used to be 3.6% resistance. It's now up to 12.8%. So that A on the test is now a B. What about Bactrim? I'll just throw some Bactrim at it. Used to work 97% of the time. Now that's down to about 90% of the time. Clinda resistance. Ooh, we never were doing great. That was always a C student, and now you're moving down into D category. So less than 70% success when you do that. Now, macrolides, just forget about it. 73.5% and 60% resistant to those macrolides. That Z-Pak is not useful for that MRSA. Now, interesting enough, what about the MSSA? Because I see people say, well, I don't know, MRSA, MSSA, I'll just throw a little doxy, it'll cover both. It's a 91%. So we're now at 9% of MSSA is resistant to the doxycycline. Now, They have regional stratification over time showing that the Northeast had slightly higher rates of clindamycin resistance, right? So all those ER docs using clindamycin, not so great anymore, but lower rates of the tetracycline resistance, while the South had notably higher rates of resistance to the tetracyclines and the Bactrim, the TMP sulfa, particularly among the MRSA isolates. All right, and I will wrap up, I think, the last article here with the article Trends in Empiric Broad-Spectrum Antibiotic Use for Suspected Community Onset Sepsis in U.S. Hospitals, published in JAMA Network Open. And we read here in this cross-sectional study of 6.3 million adults admitted to 241 U.S. hospitals between 2017 and 2021. Half of all that MRSA and anti-pseudomonal beta-lactam antibiotics were prescribed for community onset sepsis, but only 9.5% of the suspected community onset sepsis treated with broad-spectrum antibiotics had actually these resistant organisms identified. So this is what happened. They're like, oh, they got a white count, they got fever, that's sepsis. The next thing you know, they're on vancomycin. I'm like, vancomycin for the community-acquired pneumonia. Didn't we just point out that it's going to double your mortality? All right.
Just got to get a sign.
All right. And those ER docs, they're not listening to us, Sarah. I hate to tell you.
You never know.
All right. If you're an ER doc and you listen to our show, you send us any shout out you want. We're gonna make you famous. All right. And then after you do that, you can sit back and enjoy our fungal section and be sure to watch The Last of Us. The article Challenges to Implementing a Vaccine for Coccidiomycosis was published in Open Forum Infectious Disease. And I thought it was sort of interesting. I mean, basically, the authors just opine on what should be considered during the development of a vaccine. I mean, you and I should write one of these. Hey, Sarah, I'm thinking we should make a vaccine for bug X. And then we say things, and I'm going to quote them here. Based on the fungal life cycle and host immune response, it is unlikely that a successful vaccine will prevent coccidioidal infection. Did they miss the memo? Vaccines don't prevent infection, they prevent disease. They go on. Instead, it is probable that it will result in an enhanced control of subsequent infection through a vaccine-induced specific cellular immune response. Yes, that's the way vaccines work. The primary goal of vaccination would thus be to prevent symptomatic primary pneumonia. If such a vaccine were effective, it would reduce initial visits to primary and urgent care clinics. That's a good outcome, and emergency rooms, as well as reduce unnecessary antibiotic prescriptions, repeat clinic visits, and lead to an overall reduction in the documented healthcare costs. So I kudos for opining on this, and we shared your article.
Well, I'll give you a break. I think I put several fungal papers in. The first one is an article from OFID, Cryptococcosis Associated with Biologic Therapy, a narrative review. And I think when I was skimming this earlier, I saw the C. I was like, oh, it's another crypto paper, but yours is actually Coxie. So anywho, these authors looked at opportunistic cryptococcal infections and various biologic therapies that patients were receiving, highlighting risks and clinical outcomes. So it's just a nice summary. They kind of walk through the different categories. So I'll just point out some of those, like basically the headers. The first sort of group would be TNF alpha antagonist. And so most of the published cases are related to infliximab, but there's also a handful out there with adalimumab, etanercept, and certolizumab, typically for IBD or RA. The risk is not equal, sort of looking at those published cases, but I don't think I knew this. Infliximab binds to the monomer and trimer forms of soluble TNF and actually assembles a more stable complex than the other antagonists like etanercept, which is why it seems like those patients are at more risk for infection. So that was a nice nugget that I didn't know from before. The next group would be ibrutinib and other Bruton tyrosine kinase inhibitors, but really most of the cases have been associated with receiving ibrutinib. Fingolimod, that oral med that has been used for relapsing multiple sclerosis, leads to rapid reduction in lymphocytes, and patients on this med have a significant reduction in the circulating CD4 T cells and really activation of T cells, which leads to reduced production of interferon and TNF alpha and others. So that was sort of linked to cryptococcal infections. And there's some other ones in there like JAK-STAT inhibitors, monoclonal antibody against CD52, which is alemtuzumab. But really, all of these are generally sort of blocking or interfering with that Th1 macrophage activation pathway. If people dig back into their flow charts that they've looked at, and that's sort of linking to that risk of the cryptococcal infection. But I thought this was a nice summary. They basically report out how many cases are out there in the literature, if they were primarily pulmonary cryptococcal disease, was it leaning more towards disseminated cases, and so on. And then I put a picture. There's a really nice figure 1 that is sort of like a pathogenesis and has the different categories of biologics. So it's a nice image.
Very complicated.
Yeah. So if you had shoved that way down, they bring it back up for you. It's very nice. And so this next one I pulled, it is slightly beyond our usual 2-week mark because it was released in early June, but I'm just going to say I was sick and I decided to include it anyways. It's from Intensive Care Medicine. Pneumocystis pneumonia in intensive care, clinical spectrum, prophylaxis patterns, antibiotic treatment delay impact, and role of corticosteroids, a French multicenter prospective cohort study. That summarizes most of things in the title. The study took a look at 158 severe PJP cases and what ended up being 36 of the 49 participating ICUs, which were in France. And this is in a window of 2020 to 2022. And so they really wanted to look at that, again, severity, clinical spectrum, outcomes, and any association between delayed start of antibiotics and how useful were those adjunctive steroids that patients receive. I thought it was interesting. 70 of the cases, or 44%, were not definitively classified as proven or probable PJP. It was based on the bedside clinician diagnosis, it sounds like. And they did report a pretty high frequency of co-infection. So like 44% having any sort of bacterial, viral, or fungal co-infection. So that was also interesting to me because I feel like many of the times I've treated patients with PJP pneumonia, they actually generally didn't have another coexisting infection. But of interest in my mind is 66 or 2/3 of the patients were immunocompromised. So 66%. And then by numbers, about 66 patients had some form of malignancy. There are 29 patients living with HIV, 14 solid organ transplant patients. So I think it's helpful to reinforce, we kind of already knew this, that we're not really seeing PJP in the setting of HIV, but often in these other conditions. And almost 1/3 of those cases were patients who were immunocompromised related to inflammatory or autoimmune type diseases. And so they reported quite a high mortality. The mortality rates were 31.6% in the ICU, 35.4% while hospitalized, and 40.5% at the 6-month mark. They found that 29% of patients were already on PJP-specific treatment before coming into the ICU. The rest started in the ICU, and 12.7% received their first dose of PJP-directed antibiotics after 96 hours. And that, starting directed or curative antibiotics after that 96 hours in the ICU was associated with a faster occurrence of death. They did, although not really sort of dedicated to answer this question, they did look at the use of steroids, which was associated with a faster occurrence of death. And I think I don't know that this totally answers that question, and we don't maybe completely understand who benefits from adjunctive steroids in the non-HIV PJP infection settings. And they did note the lack of prophylaxis in patients that sounded like they could have been candidates. So about 12% were not on preceding PJP prophylaxis. So I think some of the take-homes we kind of already knew, thinking about PJP and critical immunocompromised patients, starting treatment if you have a suspicion. And then, I think we still need help understanding the true efficacy of adding adjunctive steroids in this setting. that hopefully will be answered with research in the future. So if people are looking, I think there's people already trying to answer that question. But I think this is my last one from the fungal section, and I was super excited about this one. It's from OFID, a diagnostic stewardship intervention to improve utilization of 1,3 beta-D-glucan testing at a single academic center, 5-year experience. This summarized results of a diagnostic stewardship intervention to provide basically an algorithm to improve how people use beta-D-glucan. So instead of being able to click in the computer and order a beta-D-glucan, instead the EHR prompted clinicians with a test request order that basically directed it so that someone had to approve to actually process the test. And so they list their approval criteria in more detail, but I'd say generally, more briefly, their criteria is basically immunocompromised patients, those in the ICU, those on empiric antifungal therapy, or those who can't get some sort of invasive diagnostic procedure. Generally, we're going to get approved. But it's crazy. The number of beta-D-glucan tests decreased by 85%. So from 156 tests to 24 in the comparing these pre and post intervention windows. There's no patient harm, meaning they didn't find a delay in invasive fungal infection diagnosis or IFI-related deaths in those who had a rejected beta-D-glucan test. And it's estimated that they, in just test costs alone, avoided probably $36,000 over 5 years. And honestly, that doesn't even include all the indirect costs when someone calls you and says, there's this slightly elevated beta-D-glucan. We also got this CT scan, these follow-up tests. So I think it's probably a lot more than just the cost of the test. And I just thought this was delightful. I will say that this is it sounds like an academic center that doesn't have an affiliated stem cell and solid organ transplant center. So I'm sure that getting everyone on board to push out an initiative like this in other settings that do have a large population of those patients, that may be a bigger hurdle, lots of meetings and reassurance, but it really makes me want to try something similar because this is awesome. And there's no way to sort of calculate all the clinicians who went in to order a glucan and probably saw it and were like, oh, I guess I don't need it. So very cool.
All right, I see the delight.
I mean, it's lovely. People did well. They saved money. There's less ordering of the test when it didn't need to be done. It's
and you
great.
Don't like the test to begin with. So, yeah.
It has some
the
rare
poor little
places.
mom and pop place up there in Falmouth, just trying to be helpful.
Just trying to help the crabs.
Exactly. All right. Well, parasitic, be sure to listen to This Week in Parasitism. And that's where you're going to have to get your parasitism stuff this week. It's looking a little lonely there. But that's gonna bring us to the end. So, Sara?
Yeah, that's the end of our podcast for today. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher. And we love to get your questions, comments, paper suggestions, and love to hear if any ER docs actually listen. And you could just let us know at puscast@microbe.tv. And if you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or go to Parasites Without Borders, parasiteswithoutborders.com, click on the donate button.
I'm Sara Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com.
And I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center. I just finished another block of being the attending there, and that was great as always. Or you can find me at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.